Welcome to the discussion of the Uworld question ID 106515. The patient is male, he is 40 years old. The reason of visit, it's a follow-up after surgery, so I'm expecting that he is visiting the same doctor who operated him. The operation was nissen fundopilcation, done 6 weeks ago. Nissen fundopilcation is a reserve surgery for persistent GERD. In severe cases, not managed by any medical therapy, then you can perform nissen fundopilation, which is basically wrapping the upper part of the stomach around the lower esophageal sphincter so the GERD symptoms disappear. The patient is complaining nausea, early satiety, epigastric discomfort, which is dyspepsia, and postprandial bloating. These things showed up after surgery. Postprandial bloating is important thing to note. It's not consistent bloating. That might differentiate it from another thing, as we will see in the next few slides. The associations of this problem, there is no constipation, there is no diarrhea, there is no dysphagia, there is no dysphagia, but there is weight loss and food aversion. So, weight loss is an alarm symptom. You should perform an endoscopy in cases of dyspepsia with weight loss. By examination, the vitals are completely normal. By inspection, there is normal surgical incision and no distension. So, why did he mention surgical incision? Because this is the routine thing you do after follow-up for surgeries. You check for surgical site infection or wound adhesions or anything related to surgical wound problems. It was normal, and there is no distension in the abdomen. You can see it by inspection. If there is a distension, some form of distension, you can percuss it as well and see if there is gas in the region mentioned, maybe gastric region or upper abdominal region. There is no distension. By palpation, there is no tenderness. This somewhat excludes gastric perforation, maybe any gastric structural defect or disease. Instead, this might be a motility disorder. Functional thing. By auscultation, there is normal bowel sounds. Why would you auscultate the bowel? You would do that to see if there is an obstruction. If there is an increased bowel sounds, that might indicate an obstruction in the small bowel. The investigations requested is upper GI series, which is normal. I don't know why it was done. I seriously don't know. What I'm expecting that this was confused or not confused, replaced. Instead of saying he performed endoscopy and it was normal, they said upper GI series. I believe the question meant endoscope, not upper GI series. Upper GI series is basically perium study or any contrast study with radiation like X-ray. But what must have been done is endoscope, since we have weight loss in this case with dyspepsia. So, and in the explanation as well, in the explanation of this question, they keep on mentioning that you need to perform endoscopy for patient with gastroparesis after a nissen fundopilation. So this is wrong, I believe. It was meant to be upper GI endoscope. Must be normal, and then you perform other things. Why you must do upper endoscopy? To exclude obstruction. Okay, upper GI series excludes obstruction. I'm not sure which one is better, but I believe that endoscope is much way better in excluding upper GI obstructions. So this is a case of gastroparesis after fundopilation, because you should know that after nissen fundopilation there are some expected complications. You should teach the patient about them. They are dysphagia. It's not discussed here. There is absence of dysphagia. It's not discussed, but it's self-resolving. That happens during the first 12 months. There's no dysphagia. It's not discussed. It's self-limiting, so conservative thing. And gas bloat syndrome, that comes up with bloating, but it's not postprandial, it's consistent. And you treat this bloating by conservative management like smethicone and avoidance of carbonated beverages. But in this case, it's gastroparesis. Why? Because there are certain symptoms that support this diagnosis, like postprandial bloating, postprandial emesis of partially digested food because the stomach didn't move well. Okay, it digests food, but not completely, so it's thrown back, and after throwing up, the symptoms are relieved. This bloating, this distension, this fullness. And also there is food aversion and early satiety that led to weight loss. These are the symptoms done. What caused this gastroparesis after nissen fundoplication is inadvertent vagal nerve injury during surgery. So you need to notice this, that during nissen fundoplication you should take care of the vagus nerve. Just try to avoid hurting it by any means. Like the parathyroid, this is more common, more famous, like parathyroid injury during thyroidectomy. Here, in nissen fundoplication, try not to hurt the vagal nerve as a surgeon. So take responsibility, try to avoid hurting the vagal nerve, because the vagus nerve is the one responsible for gastric motility. So vagus nerve is injured, no gastric motility, there is gastroparesis. How do we diagnose that first? We have to exclude obstruction by esophageal gastroduodenoscopy, which must be done in the question, as I said, and in the explanation they keep on mentioning it, and do gastric scintegraphy emptying scan. Gastric scintegraphy, you use certain method to see if the gastric emptying is well or not, and you will see gastroparesis, delayed emptying. So this is the diagnosis of gastroparesis. How do we treat it? By metoclopramide, which is a prokinetic agent, and frequent meals, small meals. You take frequent meals instead of taking one big meal and fill the stomach completely. You can take smaller meals and frequent meals with low fat and low fiber, because these things bloat the stomach further. And gastroparesis is typically associated with diabetes, but in this case it's associated with vagal nerve resection or injury somewhat. So it's the same treatment basically for both of them. Prokinetic agent like metoclopramide. Erythromycin is also a prokinetic agent, but I don't know if it's used clinically in a clinical practice or not, because this is erythromycin. It has side effects. Metoclopramide as well has side effects, but in this case we need to use it in order to relieve these symptoms. So metoclopramide makes the stomach empty faster. And frequent meals and low fiber and low fat diet to relieve this distension or decrease the chance of having bloating. And that concludes this question discussion. If you have any question, do not hesitate to leave it in the comment section. Thank you and good luck.